Bonsoir. Welcome. Thank you all for coming to Politico's great personalized medicine debate. I'm very excited about this because I founded an Oxford-style debate club when I was in college in Washington, D.C. Very glad that we're doing this event today, and specifically on personalized medicines, to know how central these breakthroughs are to European health policy and European policy more broadly. We need only look at the new work program for Horizon 2020 in its last year. There were several projects that highlighted the centrality of personalized medicines, not just to actually helping patients, but with transforming European industry and services more broadly as part of its competitiveness goals. And also there's a new project working with European and Canadian researchers on personalized medicines to improve transatlantic relationships. And that's one of the reasons it makes it so perfect that we're discussing this at an outside-in discussion. Outside In is a Politico series that we started in DC in 2015, and it focuses on the intersection of healthcare and tech, and our goal is to bring together outside experts from both Brussels and Washington. So thank you so much for both being here and for watching us online, and to our partner Philips for making this possible. I would encourage you to tweet. You can tweet using the hashtag #OutsideIn, and there will also be, as with all of our events, an opportunity to ask questions. So keep those in your head. We'll have a roving mic come around the room when we're ready, and please give us your name and organization when you ask your question. We also will have an evaluation form to fill in, so we always try to make our events better. Please help us out by doing that before you leave. Now I'm very excited to introduce Jan Kimpen, and he's the Chief Medical Officer for Philips, and he'll give our partners introductory remarks.
Good evening, everybody. Are we ready after a long day for another debate? I hope so, because I'm very excited to welcome you all to this 6th Politico Philips Future of Healthcare event, the Outside In event. And we have a great team for this evening. We are going to talk, we are going to ask questions on one of the most exciting areas in healthcare, which is personalization of healthcare, the great personalized medicine debate. That is what we are going to go through tonight. But before giving a short introduction, just to put everybody on the same plate and to kick off the meeting, I would like to extend our thanks to the Dutch permanent representation here in Brussels at the European Commission, and for hosting us here in the middle of the Tower of Power, so to speak, in the middle of everything that is happening in Europe. Thank you very much for having us here. I think that everybody believes now, that everybody is convinced that the new paradigm of medicine, of healthcare, is value-based healthcare. And you could translate that in another sort of term, which is called the quadruple aim. Better patient care, better quality of patient care at lower cost, but also with an enhanced patient experience, and last but not least, an enhanced healthcare professional experience. And I deeply believe that personalization of medicine, making a treatment, a diagnosis, as personal as possible for an individual patient, will address these issues, will address both the quality of care, which seems to be a no-brainer, that if the more personal your care is that you get, the more happy you will be, the more satisfied you will be with the care. But I also deeply believe that the other aim, lowering the costs of healthcare, taking the waste out, industrializing care, so to speak, is also something that can be addressed by personalization. Now, talking about personalization cannot proceed without addressing digitalization. Digitalization, connectivity, healthcare informatics are a sort of cornerstone to make personalized medicine a reality. I don't think that we can go forward in the healthcare world without embracing this digitalization, this connectivity. Because only by integrating the data, as was stated in The Economist, I think in the May issue this year, that data is the new oil. Only by integrating all data that patients collect themselves, that are coming from the systems in the hospitals, that are maybe coming from other databases, adding artificial intelligence to that will make personalization of healthcare possible. This was a little bit of a theoretical introduction, so let me talk a little about two examples in Philips. First is our Dream Station. As we all know, sleep apnea with all associated sleep problems, not being rested in the morning when you have to go to school or to work, is one of the biggest problems in healthcare now. It plays at home at the home of the patient, and it causes a tremendous amount of harm to patients that have sleep apnea and that are not rested well in the morning. We have solutions for that. We have masks, very smart masks, very intelligent masks, and we can apply positive airway pressure through these masks so that a patient can breathe normally at night, rest better at night, and be more rested in the morning. However, I don't know if you know somebody that wears these masks, or maybe you wear a mask yourself. It's no fun. It doesn't look nice, and it doesn't feel comfortable all the time. Although we try to improve the masks and make them more comfortable, they are not an ideal thing to wear on your face during the night. So the compliance with these masks is very low. It's below 50%. That means that less than 50% of the patients, or in other words, individual patients are wearing the masks less than 50% of the time because they feel that they are causing more harm or more uncomfort than comfort or benefit. What we did is we connected a remote software to the mask, where we measure remotely during the whole night the sleep pattern of the individual patient. So that in the morning when he gets up, he can look at his iPhone or at his iPad and he can judge how he slept during the night before. And he can connect that to his own feeling in the morning. And we saw the compliance with these masks going up by more than 20% just by building in this digital feedback loop that he could even take to his doctor to show him the sleeping patterns he had over the last month or the last 2 months. That's one example from the hospital-to-home space. Let me give you a second example, an example from the hospital. Just imagine a pathologist. We all know that the incidence of cancer is increasing. At this point in time, in 2017, 14 million new cases of cancer are diagnosed every year. 8 million people die from cancer every year. And this is increasing. And it's most probably hitting the 20 million new cases a year in a few years. That brings an enormous burden on pathologists. Pathologists that get the biopsies to their laboratory, that have to sit behind the microscope. And just imagine what a pathologist is doing. He prepares the slide, he cuts the slide in pieces, he puts them on a glass slide, and he looks through the microscope. Just imagine the burden on these pathologists. And I talked with pathologists last week in one of the biggest pathology labs in the Netherlands. And he said, listen, it takes 5 to 7 years after the training of a pathologist before an individual pathologist feels comfortable when he sends out a report. Because he says, what I am sending out to the doctor now is going to determine the treatment of this patient, or even worse, it's going to cause the doctor not to give treatment because I might have missed the tumor. How could we enable the work of these pathologists? By scanning the glass slides into a computer. And Philips has now the only FDA-cleared digital pathology scanner in the world. Then the pathologist doesn't have to look through the microscope anymore and look for the abnormal tissue. He can see the tissue on his screen. And he can do with the mouse of his computer the same things as what he can do with the microscope. But on top of that, we stacked a software layer on this slide, which does an automatic contouring of the abnormal tissue in the biopsy. So the pathologist is already directed to something that is abnormal. So there is a much lesser chance of missing a malignant diagnosis. And what we will develop from next year onwards is algorithms that can even help him when he looks the first time at the biopsy, grading the tumor already because of the histopathology characteristics that are there. And if he still doubts about the diagnosis, he can just send the biopsy to wherever he wants in the world, to the biggest expert on that cancer, to have a fast look and get the result back. So in this way, you can see that we can really personalize healthcare here for patients at home and for patients in the hospital that have their biopsies monitored by the pathologist. That are just two examples of how digitalization, connectivity, and all these other health informatics tools can make healthcare better, cheaper, and more personalized. But how do we scale it? Which are the topics we have to think about? And that will be the conclusion of my introduction. There are a few items we will have to address going forward to really scale this personalization. And first of all is standardization of data. If we want to use data, share data, bring data, even give data to the patient, he owns the data, by the way, so that he can take him to another doctor or even to another country, there has to be some standardization. Standardization in collecting the data, standardization in storing the data, and in analyzing the data so that they can be shared more easily. The second item we have to address is outcome measurements. We are not supposed to measure just standard procedures anymore. We have to measure everything we do to a patient, how that influences the outcome after the treatment, after the diagnosis and the treatment is done. And I am very happy to announce that Philips is also engaging with consortia that work on these outcome measures, like, for example, ICHOM. The third item we have to address, the third topic we will have to deal with is change management, and that is most probably the most difficult part. I have been a pediatrician for almost 25 years. I have run a hospital for 8 years, and I know that when you want to bring the digital world into a hospital and into the outpatient room of a doctor, there is some convincing to do. Doctors, healthcare providers, payers need to think differently, need to embrace digital, and need to be convinced that doing the things you did yesterday just a little better is not going to move the needle on healthcare and on personalization of healthcare going forward. And last but not least, the fourth one is patient engagement, patient education. The patient will increasingly want to take, almost demand to take, responsibility for her own life, also when her own life is maybe not so much fun at this point in time because she is sick. So engaging the patients, making patients a partner in the ecosystem, a full partner in the ecosystem, is the fourth very big item we have to address. And by this, I would like to wish you a very, very inspiring debate tonight, because only by joining forces, by working together, by collaborating, industry, together with all the different stakeholders in the ecosystem, only if we can do that, we will improve healthcare, we will personalize healthcare, and hopefully we will cut some waste out of the system. I wish you a wonderful debate tonight and a wonderful evening after the debate. Thank you very much.
Thank you so much, Jan. And now I would like to introduce the Commission's Irene Norstedt to the stage. Thank you for being here.
Thank you for inviting.
So we're here for a debate about personalized medicine, but your job is head of unit for innovative and personalized medicine at DG Research. So I think we can predict what your take on what the conclusion should be. But what exactly does personalized medicine mean to you?
So personalized medicine is a very broad concept. And we started around 2010 to look into this area because we saw, of course, the avalanche of omics coming through and the way that really can improve healthcare.
What do you mean when you, sorry to interrupt you, but what do you mean when you say omics?
Omics, following the sequencing of the human genome, follows a range of different omics. We have epigenomics, metagenomics, we have metabolomics, proteomics, all kinds of omics. We're going to come to economics soon as well. But this has sort of created an avalanche of information and data that really can help us progress our understanding of health and disease. So when we saw that, we have invested a lot in that historically from the Commission's research program, and we saw that we need to see how we can bring this forward, and that's really when we started to engage in these reflections on personalized medicine. And what we have seen through numerous workshops, conferences, etc., is really a very broad area, all encompassing really how you can use any type of information to better predict how an individual would be able to respond to treatment or preventive measures, etc., in view of really providing the best health outcomes for that individual.
And what are some of the biggest misconceptions about personalized medicine?
One of the biggest misconceptions when we talk about personalized medicine is that we talk about personalized medicines, and we end up in the discussion about pharmaceuticals. And we want to draw that back to personalized medicine, which is a medical model for health care, which really builds on this ability to capture, as Jan mentioned, a lot of data to enable that prediction for that particular patient. And with that information, you can develop a preventive measures, also could be also therapeutic pathway that would really suit that patient.
And whether we are talking about pharmaceuticals or individualized preventive measures, I think one of the big questions we're going to be asking during this debate is, are they really accessible to everyone if we have to do an individualized thing for everyone?
So we need to look at this in a global context, and I think you also alluded to waste in the healthcare system. WHO has estimated that up to actually 40% could be gained by not prescribing wasteful or ineffective treatments for patients. We also have a big problem with adverse reactions. There it's predicted that about 6% of all hospital admissions actually is due to adverse reactions to treatments. Those could be avoided by much better prediction to look at the therapeutic outcome or the health outcome for that particular patient.
And audience, just start thinking of your questions now. I'm going to come to you in just a few minutes. But given that personalized medicine as a broad array of approaches. We just talked about Horizon 2020 devoting millions of euro to that. Is the current funding environment, is it matching the priorities that we should be having, or is it more just kind of limited to new discoveries as in pharma at this point?
No, we are investing in a broader range of areas. So over sort of the last 10 years, we invested more than 3.2 billion from our programs in a broader range across the whole innovation cycle. So that goes from, developing all kinds of type of diagnostic tools, screening programs, better understanding of health and disease, molecular definitions of disease. Also, we go all the way into HTA methodologies, clinical trial methodologies for small populations.
And sorry, so HTA, probably familiar to most of the people in the room, but health technology
assessment methodologies. So a lot of methodological work. We are also funding some pilots of really putting personalized medicine into healthcare. So we have one particular project which is called ubiquitous pharmacogenomics. So
definitely have to explain that one to us.
So that one is a project where by using pharmacogenomics that really can help predicting how an individual would respond to a particular treatment, to really help bringing that information out into the healthcare setting, to give that to the healthcare providers to make sure that they would not prescribe a particular therapeutic pathway for an individual that would have very severe adverse reactions. That would be really, really helpful. And here we have a collaboration of 6 countries. It is coordinated from the Netherlands, and it represents a very broad variety of healthcare systems we have in Europe. And we are very excited by this project and really looking forward to see how it's moving forward. And this is something that we really look into. We have just launched our new work programs for the 3 coming years for Horizon 2020, and we are looking into having more of these type of projects, really to work out how to roll this out into healthcare, because what we really would like to do is to build up the evidence base for how this actually can work in practice.
Thank you. And any questions in the audience? We have a very short time, so if you're being shy, you'll miss your chance. All right. Well, in that case, I still have more questions. So, in March 2017, the International Consortium for Personalized Medicine put out an action plan, and that action plan said that that by the end of this year, I'll have to take out my own notes, but the European I think Action Network. European Research Area Network of Personalized Medicine would begin working. So what's the status of that, and what are some examples of some projects that we should expect coming out of that?
So for those of you who do not know what we talk about here maybe, is that we have a very big collaboration across the European countries in something called the International Consortium for Personalized Medicine. It is something that was initiated a couple of years ago when we were approached by many countries who asked us if we could help sort of start coordinating research funding organizations in Europe to come together to jointly look at what research we could sort of jointly progress on and co-invest in. What's interesting with this consortia is that, we started off with research funding organizations, but actually also a lot of health ministries and regional authorities have started to come in and would like to collaborate in this. Together, these organizations, which represent really across all of Europe, and also Canada, as you mentioned, is also part of this cooperation, has developed this action plan, which was published. And actually by December, the ERANET, which is one of the programs we do have in Horizon 2020, where research funding organizations can come together and co-invest, should start its operations. So there you can really start to see, the actions on that action plan to be invested. invested in. So exactly what the first calls will be, we don't know yet because it hasn't started yet, so we will have to see. But it's really fantastic to see that if we look at the IC permit and the participants in this particular ARANET, we are really addressing all across Europe. And that, I think, also you mentioned about accessibility, etc., and the perceptions. This is something that really engage all the countries, both from the research side, but also from the healthcare side. And we see more and more engagement of health ministries to come into this work and start to see maybe on, different type of healthcare models, etc., and start to, work in research and develop those models and see how this could be done.
I'll give the audience one more chance to ask a question. Am I missing somebody in the back right there?
Hello, Tresha Bowles, Independent Government Affairs Practitioner in Healthcare. Just a question. Jan Kimpen also pointed out to the importance of change management. What do you, in particular, referring to, on the one hand, healthcare practitioners, hospitals, payers, what do you see as the kind of the biggest obstacles, barriers to seeking greater adoption of personalized medicine in Europe?
I think one of the really important things that you also alluded to is to provide the healthcare providers with tools that actually can be used in the healthcare setting. There is so much data that now is being gathered. We have both from the research point of view, but also starting to come from the healthcare side to bring together all this information. We really need to have very good data system that can capture the data. We need to work on the standards, the harmonization, and also how to interpret all this data and provide this information in a easily accessible way for healthcare providers. So that is really, really important.
Well, that was a great introduction to this topic, and now it's time for the main event. And so thank you so much, Irene, for joining us. And I would like to invite my colleague at Politico, Carmen Pon, to the stage.
Hi, everyone. It's good to see you. My name is Carmen Pon. I'm a healthcare reporter with Politico. And tonight, I'm actually quite excited because I'm moderating my first Oxford-style debate. And what I'm actually even more excited about is that my role will be quite minimal. So that's, that my work is not hard at the end of a day like today. So it's a new concept for me and probably for some of you. So I will spend a few minutes explaining to you what's going to happen next. It's an Oxford-style debate. Unlike Sarah, I haven't been in one, also in school. I wasn't really so good at argumenting things. That's why I became a journalist. So we will have two speakers on each side, one for the argument and two for the argument, and the other one's against the arguments. The argument is on your cards. This house believes that personalized medicine is the key to sustainable healthcare. And in a minute, I will ask you to vote for or against that motion. And one thing that I wanted to make clear, also so you understand a bit the position that our speakers are in tonight, is that obviously there's no black and white in many conversations and in many debates. And obviously personalized medicine is clearly one of those. So we have asked our speakers to be, for one side or the other for the sake of the argument, but that doesn't mean that they're completely against or they're completely for the motion, and that they do not understand the differences and the nuances and the grays that are in this debate. So if you would humor us and play the game with us tonight and allow our speaker to be opposed or promoting this argument for the sake of the Oxford-style debate. We will start with 4 minutes on each side. So each of the two speakers on each side will have to present their arguments. And then we will end with closing arguments, which will be 2 minutes long. I'm usually not very good with keeping time, but tonight my main role is to keep that time. So I will try to be nice but firm in telling people off when they've gone over their arguments. And I have here my colleague Julia, who will be my timekeeper. For my side, as I said, my role is easy. I'm supposed to be a journalist. I'm supposed to be objective. I'm not going to be on any of the two sides. I'm going to try my best to be on the side of time. So, as I said, we will vote you have these nice cards on your chairs, or you hopefully took them. You didn't sit on them, but if you sat on them, just look for them. So there's the green one if you are for the motion, if you believe that personalized medicine is the key to sustainable healthcare, and the red one if you're against that. So I will ask the people who are for this motion to raise their green cards. Okay. Quite a few green cards. Thank you very much. People who are opposed to the motion, please raise the red side. Okay. Okay. Fewer, but quite significant difference. We will run this vote again at the end of the debate to see if our speakers have convinced you of the opposite of what you think now, or whether your opinion remains firm. I will try as much as possible to count or to figure out if there have been significant changes in the room. So without taking too much time speaking longer, I would like to invite the speakers on stage. On my left side, there will be the people opposing the motion. So that will be Mrs. Anna Bukšić from the project MOCA, and Stanimir Hazardžiev, who's a board member of the European Patient Forum. If you would want to take your seat on my left side. And on my right side, we will have Nick Klazinga from the OECD and Peter Capitan for Inspire for Life. Thank you. Thank you very much for joining us tonight and for agreeing to play the Oxford-style debate game. We will start with each speaker presenting their main arguments of why they think this motion is right, that they're for it, or why they think this motion is not right, or they want to oppose it. So 4 minutes, we will start from my right with Mr. Nick Klazinga. You have 4 minutes for your arguments.
Madam Chair, ladies and gentlemen, personalized medicine is the key to sustainable healthcare, and that's just a consequence of logical thinking. Just look at the two concepts: sustainable medicine and sustainable health and sustainable personalized medicine. In essence, medicine is the application of scientific knowledge and technologies. And we have organized a world of professionals and services that apply this scientific knowledge and these technologies to individuals. If there are ways to increase the value of that interaction by making the knowledge more personalized and making the application of the technologies more personalized, that increases value. It helps people to realize their potential health, because that's what we do in healthcare. Doctors don't produce health. People realize their own potential health, and we build supporting mechanisms, and we use professionals and others to do that. So again, if that knowledge becomes personalized, that we don't have to wait for results of trials, but we can really capitalize and learn from the existing data and shift to an era of effectiveness research, value will increase. Sustainability of healthcare and healthcare systems is usually seen as financial sustainability. Could also be environmental sustainability. But in the essence, it's whether the value that I get here is still in balance with the benefits that I get here. And then it's just a matter of logic. If I'm improving the benefits and the value here, the collective will be better here. However, we should not stop there. So I will use the remaining 2 minutes just to make the argument that a key needs to fit on a lock to open a door. And that means that we just don't only need personalized medicine, we need person-centered healthcare. That was the theme of a large ministerial conference in January of the OECD Ministers of Health. And basically, I learned 3 routes of things that should happen to make the key fit to the lock. One is the digitalization, really knowing how to use the data that become available. The OECD Council came with recommendations on data security and privacy also in January, and how to set up governance mechanisms. But we know that in working with member states, that is a real struggle. The essence of the Council recommendations is that it's not black and white, data, absolute privacy, absolute security, but you need all the time balance that with the learning and the benefits of having the information. Making that decision for a safety issue is different than making that decision in other situations. The second condition is waste. Reducing waste. There's a lot of waste in the healthcare system on the clinical level, operational level, system level. Dealing with safety, which costs at the moment about 15% of our hospital costs. Promoting choosing wisely. Those are very important issues. And yes, there is still a lot of waste in the present agenda. Just think about all the admissions to hospitals that have to do with non-compliance or wrong compliance of the use of medication. The third part is system redesign. If we want to have personalized medicine, we can't deal with the classical hospitals and the classical medical specialists anymore. We need different ways of knowledge brokering, different ways of learning systems, and that is a challenge, to really redesign the system in such a way that they are really integrated, and if we put the incentives in place, including financial incentives, that help us to produce value. So yes, I believe that personalized medicine is the key to sustainable healthcare.
Perfect. Thank you so much. Just on time. You avoided me being rude and interrupting you. I will go now to the opposing team, and I will give the next 4 minutes to Mrs. Anna Bukšić to explain why she is against the motion tonight.
So, thank you very much for the invitation to speak, to be the devil's advocate today. But before I do that, I would just like to clear up a confusion. I do not work for Eurordis. I respect Eurordis. I work together with Eurordis, but I'm part of the project called MOCA, and the MOCA webpage is hosted by Eurordis, so I guess this is where the confusion comes from. That being said, working with orphan medicinal products gave me a sense of déjà vu when I started looking at personalized medicines, not medicine. Because if you look at it in a cynical way, this was just an attempt by the pharmaceutical industry to expand the orphan drug model. You take an indication, slice it into small little bits, you have small clinical trials which are cheap and easy to make, and then you can get a whole lot of money for that. Great thing. If I worked for the pharmaceutical industry, I would be doing that too. So I'm not bashing them, just congratulating them for a great model. That said, this model of personalized medicine did bring some spectacular successes in the area of cancer care. We have got some medicines, we had spectacular cure rates, and we even have medicines now where the indication is based on genetic markers and not on anatomy. So, what did that tell us? Yes, this concept can work, but it's still not very precise. It could be, and it's only working in cancer and in some indications. With other indications, there's still a lot of problems. We don't have personalized medicines for depression, and that would be really helpful. But what else did it tell us? This type of personalized medicine is not part of the solution for sustainable health care. For payers, this is part of the problem because these medicines are so expensive. And there's no way that this kind of a model can work for all indications. It's simply unsustainable from the payment, from the payer's point of view. Because, again, this would also lead to a sort of virtuous or vicious circle, depending on how you look at it. So if you have expensive medicines and you develop a diagnostic to make sure that it's targeted, then you can explain to the payer that this is saving you a lot of money. So then you can ask more money for diagnostics too. And that leads to an even higher level of cost, which is, again, unsustainable. So yes, the payer's experience with personalized medicine is it's not part of the solution, it's part of the problem. Can personalizing medicine be part of the solution? Maybe. The solution to sustainable healthcare, in my personal point of view, is rethinking about how we pay for healthcare. Rethinking about the scale. Does it really have to be provincial, Do you really have to separate payment from hospitals to outpatient care? How can we think about payment for medicines, especially for rare diseases, on a European scale? Can we make sure that what we pay for is actually something that works in the individual patient? There are so many ideas about managed entry agreements. So yes, if we have big data, then maybe this can be part of the solution. This kind of personalization can maybe help. Thank you.
Thank you very much. Very nice timekeeping. Thank you for that. I will go back to the proposing team and invite Mr. Peter Kapitein to explain why he thinks this is the solution to sustainable healthcare.
Thank you. I always like it to be invited by Jan Kimpen because he always gives me a line to start my talk with. And it is the more personalized medicine is, the more happier patients will be. Thank you for that, Jan. I was in a discussion a couple of years ago with a good friend of mine. He's called Stephen Friend. That's why he's called Friend. And I asked him, will personalized medicine be a success? And he said, it depends. That's normally a line from a lawyer and not from a scientist. But I think, Peter, you got a job to do. Because personalized medicine, if we do simply the things we normally do, will be hijacked by industry. And then it will be just another way of treating patients and making money. So I always listened to Stephen, and I thought, okay, I have to do some work as a patient advocate. A couple of months ago, I was in Copenhagen, and before me there was a speaker about personalized medicine. He said, will personalized medicine be a success? And I thought, what a silly question. Of course it's a success. Look at me. I am personalized medicine. I got a bone marrow transplant in 2008. An unrelated bone marrow transplant, which means that you dive into a database with 30 million potential donors, and you look for a match on the level of proteins. Now, that is pretty personal. In this globe, there is one, maybe 3 or 4 people who could save my life, and she did. I like it to talk about her as a woman. Now, where did we go wrong? Because this way of treating patients was developed 60 years ago. Bone marrow transplant was developed by a Dutchman called Dick van Beckham and an American called Don Thomas with a whole team around them. 60 years ago, we did personalized medicine, and then we dived into genetics. And we all did it. We only looked at the genetics, and we didn't look at other things. We forgot personalized medicine. Now we're back. How can we make it personal? How can we make it really individual, like the treatment that I got? I think that is advocacy. By cooperation between industry, between scientists, a lot of patient advocates, independent patient advocates, regulation, and so on and so on. Cooperation. Quit the phase 3 trials. Quit patents. And I think that is really going to happen. And that's why it's going to be a success, because we are going to treat patients with a drug that is only fittable for one individual patient. That will be too expensive. No, it won't be. It won't be too expensive. Industry will adapt. There's a lot of talk about change. Well, people do not want to change. I don't want to change. I'm married with my wife for 34 years, and the next 30 years I will be married with her too. We talk about it a lot, and we adapt. That's what we do. So if we patients take the lead and force industry and all the science and government and so on into the direction that we have done before 60 years ago, industry will adapt, take their role, and save the lives of many, many patients. Like Jan said, 8 million patients a year die of cancer. And I think that should stop, and it's in our hands to stop it.
Thank you very much, Peter. So just before I pass it on to Stanimir, I wanted to warn you to prepare your questions, because then we will have a Q&A session and they will have the challenge of responding to it in 90 seconds. So please think of nice short questions that ideally could be responded to in about 90 seconds. So now we go back to the opposing team, Stanimir Hazarjev.
Thank you very much. Should be tough actually sitting here after the three speakers, and especially representing the patients, because I'm in the board of the European Patients Forum and also leading the Patient Access Partnership. So many of you might be thinking, what is he doing there on the opposite position? Aren't the patients those who have to be really happy with the personalization of medicine? And I will tell you, yes, patients are going to be extremely happy once we get there. Because everyone likes the promises of the personalized medicine and what we hear up to now. Promises and hopes for individual approach, avoiding unnecessary treatments, avoiding adverse reactions. All that sounds really good. Having your own team who will know exactly where you work, how many children you have, what the approach should be so you can have better outcomes of the treatment that they're offering to you, and a happy system to pay for all that, so everyone is happy at the end there. Are we there yet? Would be my question, and this is what I'm going to try to focus right now in front of you, and to convince you that even though the personalized medicine sounds great, it actually threatens the sustainability of the healthcare systems right now with the current situation. The personalized medicines put new requirements to our systems and to the way that we are organized. And the previous speakers actually helped me a lot putting many of those in front of you. Like the need to reorganize the way we provide services, the need of digitalization, the need of new standards, standards of collecting data, standards of delivering services, standards for organizing those services. Do we have all those standards yet? Are we digitalized yet? Are we sure that 20 kilometers from Brussels here in a small village, they have the same infrastructure and the same way of collecting data and the same access to all the knowledge and the same access to the trained doctor and the trained nurse as the person who is living in Brussels? How about Sofia, my home city? And how about a small village in Bulgaria, my home country? Can we really say that we are ready from tomorrow to implement personalized medicine strategy in Europe so we can satisfy all patients around us? Are really the medical experts and the medical staff trained enough for all that? Do we have standards for the training? Equity is the question. Is the personalized medicine going to be something that is accessible for those who can afford it and who is going to pay for that? I cannot agree with an argument saying that at the end industry would adapt and personalization is not going to cost a lot. We all know that if you want to buy something that is prepared for you and somebody produced it for you, it will cost a fortune of money. Unlike when you go to a normal shop and you take one out of the thousands same suits you have. We all know that it doesn't work this way. It's going to be the same with the personalization of medicine. And my question is, are we ready to pay for that? Are our countries ready to face these new challenges? Are we, as society, ready really to answer this question? Therefore, I think personalization is a fantastic concept. We all want to have it, especially the patients, but we are not there yet. Thank you.
Thank you so much. And I would like to really thank all the speakers for their passion that they argue with, which I feel makes the debate the more interesting. And also to give a shout out to Stanimir, who was on a plane from Brazil last night, and he's today, and and he adapted to this time zone and managed to to come to a debate and argue. So I would like to see, I know there are many people in the room that either represent pharma or are doing consultancy work for pharma. So I'm curious if those people are outraged already by some of these arguments and want to already ask a question, or if you want me to break the ice. Yeah, there, right there. Can you put your hand up one more time? Thank you very much. And so please, short question. Each team will have to respond to it, ideally in 90 seconds. Thank you.
Hello. Pasquale Monteleone, Head of Healthcare at Freshman Hillard Consultancy. Just curious, what's your thought about a question? Could public-private partnerships help with mitigating risks and speeding up innovation? On one hand, making sure, having exposure to global best practices and activities and experiences, and on the other hand, helping local governments with advancing and improving and getting up to date, as the gentleman was saying, no matter if it's in the suburbs or in central urban centers. Thank you.
Can you, just for my sake, can you just say the question in one simple sentence?
Yeah.
I got lost
whether
halfway.
public-private partnerships could be one solution to make both sides happy in terms of using global best practices and local adaptation to resolve the big issue or dilemma. Thank you.
Perfect. Thank you so much. The proposing or opposing team wants to start responding to the question? Opposing team? You can either take the 90 seconds and do it yourself, or you can share it, whatever you feel is best.
I think public-private partnerships can be part of a solution. I am working in a sort of a public-private partnership myself, full disclaimer. However, we need to be very mindful that this would not lead to paying for a health intervention for the third time by the public, because most of the basic research does come from public money, so public pays for that. If you have a medicine or healthcare technology that is bought in Europe, it's usually paid by public money. So in a public-private partnership, when you're doing translational research or outcomes research, you have to be mindful that you're not paying for it for the third time. So I think, yes, public-private partnerships can be helpful, but this should be included in the payment for the product.
Thank you so much. Proposing team, do you want to? You have to respond, but which one of you wants to respond?
Happy to, but I basically agree. But it's more how you put the financial incentives. So if the idea is to really create value, to increase the value for patients, and on a macro level, then and that was what I said, you have to redesign, but you also have to rethink your incentive structure. So it's not just public-private partnerships within the existing structure, it is public-private partnerships and public sector and private sector within an incentive structure that is designed in such a way that it helps to create value and at the end for everybody, rather than sub-optimizing in certain niches.
I like to add something which is quite important. We always talk about value, but most of the time it's about value for the stakeholders who are not patients. And I think that when we talk about value in healthcare, the value should respond to the value that patients get from it. And of course, I'm a believer of public-private partnerships. I just made a plea for cooperation. So yes, I am, but I think the value that is added into the discussion should come from patients into that public-private partnership.
Thank you very much. We have a question over there, Mr. Goldman, and then we go to Dwayne, right there. Can you use the mic? Thank you so much.
I'm the director of the I38 Institute in Brussels and the former executive director of the Innovative Medicines Initiative. I think that we should remember that personalized medicine is certainly an important element for the future of healthcare, but just one element. And we should remind that the 4P medicine has been proposed as, the way forward. 4P means indeed personalized, but also predictive, but also preventive, and also participatory. So I will ask the question about prevention. Don't you think that we should establish more link between personalized medicine and prevention, and perhaps think about personalized prevention to make healthcare sustainable?
Thank you so much. Can I start with the proposing team?
Yeah, totally agree. Yes. And I think that is, we always run into a direction of personalized medicine, and we forget the prevention. And well, most of the time I speak about cancer, and we all know that cancers can be prevented in 50% of the time. So I think I totally agree with you, yes.
I also agree, and I spoke about optimizing your potential health, and that starts with, in an early phase, recognizing risk factors and actually supporting people in their behavior in a way that it will realize health. And there are at this moment a lot of technologies that can help you in doing that, also feedback loops and data that can support that. So when I think about personalized medicine, it's these kind of things I'm thinking about, not just about pharmaceuticals that come at a far later stage once the disease is already there. But I think by really having intelligent ways of using data about what we do and what impact it has on our health can help people to stay healthy.
Thank you. Opposing team?
Yeah. I couldn't agree more, actually, that personalization of prevention measures is probably the key for more successful prevention measures. For me, been working for years with the HIV communities and the hepatitis communities, I definitely couldn't agree more that you have to have a special approach depending with whom you are talking with. But this brings me back to the entire situation. If it took us 10 to 15 years to understand exactly what the gay population is doing and how to prevent the spread of HIV and hepatitis, and I'm not sure we know yet how to do that, how can we be sure that actually we will have the knowledge of all the different populations around Europe who have different way of thinking, different habits, different culture, and of course they would require different prevention measures. It really took us 10 years and even more to understand only the MSM population, and we still are trying to understand them in order to be effective in the personalized and tailored prevention. We are not there yet.
Okay. Mrs. Butcher, do you want to add something? Thank you very much. We're going to go to Dwayne right there for our next question.
I probably don't need the mic, but I'll take it.
Thank you.
Thank you very much.
Yep.
Good evening. My name is Dwayne Schultes. I'm the Managing Director of Vital Transformation. I'd like to take this into practical land as opposed to sky-high rhetoric, where I think we've been a lot of. If we look at Herceptin and breast cancer, we look at HER2 breast cancer. So let's look at an actual personalized therapeutic that's now going off patent, but we have a lot of data. We know that right now we can classify roughly 10% of all women high risk, 90% of women low risk, and treat these populations differently and optimize the system. And by doing so, we can save between 30 and 40% of treatment costs. Now, what does this imply? This implies, one, that personalized medicine is effective and increases the probability of success, but also it implies that we have to change the clinical pathways. Why are we not doing this, and what do we need to do that so we can create these efficiencies? It's not about the cost of the drug. Herceptin's 40,000 pounds, 50,000 euros. Still, until the generics come online. What do we have to do downstream to make sure we're making these optimizations work? What practically are we going to do, aside from just complain about the cost of the drug? Thank you.
Should we start with the proposing team?
Well, I think the general way of how you create a value chain and how you redesign the system in such a way that there are incentives for creating value, and sorry for being abstract in that sense. And of course, I can make it concrete for the differentiation in breast cancer patients, but it's still too many separate episodes. It's not one pathway. It's not linked to bundled payments. And there's not a decision-making on country level to implement that use of medication in the pathways. So yes, I think there's nothing wrong with pathway design and putting the value in place. We have the information, but it really takes a lot of engineering and so you want system change to make that happen. But I agree with you, and that's why I'm in favor of the statement, because it would create more efficiencies. Better results, but also more efficiencies.
Peter, do you want to?
Maybe to add something to that, it is that, let's be honest, a lot of stakeholders in the whole stakeholder environment do not want to change really, because there's a lot of profit in it. I wrote a book, and the subtitle of it was more or less like the more patients, the better. And there is a lot of money involved in healthcare. So if you want to change, well, that change always comes from the outside. So if you want to change that process, I mean, it took almost 10 years to have the mamma print tell you what percentage of women needed chemotherapy or not.
Thank you. Thank you. I have to stop you right there. We'll go to the opposing team.
Well, I'm a pharmacologist, not a system analyst, but I did learn that the introduction of Herceptin did change the therapy of breast cancer. And there is a test that can show you whether it will work or not. The question is, when do you apply this? So I think if you have a model like Herceptin, where you really have a good diagnostic with good predictive value and a therapy, this will change the treatment paradigm. But it still leaves us the question of how to pay for drugs like Herceptin all over Europe or all over the world.
If I may add on that, it's not only about cost, and you're right here. Here we have a model where clearly the cost is not the issue. But the issue here is the system. The people who work in this system, are they prepared? Are we ready actually as a society to say, okay, we are going to follow the same standards and the same guidelines all over Europe so we can guarantee that all patients all over Europe would be treated in the same way? We are not there yet. If we put this question even on debate, half of the countries and the medical societies would start screaming that they have to have the autonomy to do the things their own way. So besides that, it's also the infrastructure, how we are organized. Can we really provide the tests everywhere for all patients? Can we really stratify the patients, and can we really guarantee that they will get the right treatment? So all these questions are still there, and this is what I'm trying to address and to stress in my speech tonight.
Thank you, Stanimir. Do we have more questions in the room? Okay, one, the two ladies over there, and then we start right here. Yeah, thank you.
Hi, my name is Xenia Arfanis. I'm a simple radiologist. I'm a medical person, so you basically talk about my profession here. For me, this is more in the direction what you were addressing. I represent two countries, Greece and Germany, so I'm a mixture of a country that's a little underdeveloped and a country that's up there. Exactly what I wanted to say. What do you do in order to include different societies, different ways of thinking, and why are you talking about personalized medicine? Because medicine always has been personalized. Medicine has always taken the individual. A doctor always looks at the individual. They never look at the general population. Of course, they take the evidence-based medicine, but at the end, we are talking to an individual. So what does it make different from what you are talking about and what I'm talking about as a doctor who always has been practicing personalized medicine all my life?
Thank you very much.
I like that statement, yeah, because I really want to believe in it, because I think some doctors do, but most of them follow the protocols, and the protocol is excellent when you are diagnosed with a lymphoma like me, but the protocol is useless when you're diagnosed with a glioblastoma or a pancreatic cancer. So what do you do to make it unified in whole Europe? I think that the beauty of Europe is, I'm probably the only one who have a European tie, but the problem with the beauty of Europe is that people can travel along Europe, that goods and capital can travel along Europe, but patients cannot. Yes, of course they can, and they can be treated in other countries. So patients from Greece or Romania or Bulgaria, where the treatments are unavailable or too expensive or whatsoever, should be able to travel to the richest countries like the Netherlands and Belgium and Germany, who are so awfully rich. But it also have to be reimbursed, and I think that is the biggest problem, because you can get your treatment in every country in all Europe, but there is reimbursement is the real problem.
20 more seconds?
18 seconds. You can have far more knowledge in the interaction with your patients if you capitalize on the data that are available, and that makes you a better doctor. So I'm also a doctor, right? So you treated your patients, but the potential of using more data to get a better targeted, specified decision together with your patients is increasing, and we should capitalize on that.
Thank you.
I would just like to follow up on that because I think that's an important point, and I completely agree with you. When I first talked to doctors about personalized medicine, they said, well, what's that supposed to mean? We've been talking to patients as persons all the time. But if you, the challenge with personalized medicine, if you gather data, how are you going to have a system that still allows the doctor to talk with the patient while collecting data? I just read a paper the other day that about 1/3 of doctors are threatened with burnout, and one of the main reasons for this is the need to enter data. So this is really a major challenge for personalized medicine. How to get the data without burdening doctors with inputting it all.
If I can reflect to your point about the movement of the movement of people in Europe, but not of patients, because at the end somebody has to pay. I don't think that Europe has done enough to enable the countries like Bulgaria, Greece, and all other countries to provide the treatment for their patients in their own setting. And I will start with the pricing system of the medicines, which is currently setting the price according to the level of the high GDP countries and putting countries as Bulgaria, Romania, and others in a position where they have to pay exactly the same price as the richer countries in Europe. This is not fair. We have not done enough there. If we make the first steps to make a more fair system in Europe, it's not going to be full with Bulgarian patients in Germany and the German clinics begging the Bulgarian system to pay back, because this is the situation right now.
Thank you. I had to stop you right there. Right there, yes. Thank you. And then we have one over there. Thank you.
My name is Andrea Bos from the Netherlands House for Education and Research. I have a question mainly for the opposition, because we hear a lot of valid challenges, problems with personalized medicine. But I'm wondering, if you argue that personalized medicine is not the key for sustainable healthcare, then what would be that key for sustainable healthcare if you have to pick one, just for the sake of the debate?
Shall we? Okay, I'll be very short with my answer this time. I think personalized medicine might be the key for sustainable health care, but we are not prepared, and we have a long way to go and lots of things to change before we can say that personalized medicines can be the key for sustainable healthcare systems. Currently, it can actually threaten the sustainability of the healthcare systems around Europe.
I think well, this was supposed to be my closing statement, but...
You still have to make one.
Sure. I think the key to sustainable healthcare is finding new models of how to pay for healthcare, to models that include the problems that you just mentioned, how to make paying for healthcare equitable all across Europe, how to make models to pay for healthcare which are tied to outcomes. Because every medicine that I've ever been asked to evaluate was a promise. The manufacturer said, we promise, based on our clinical trials, phase 2, phase 3, controlled, uncontrolled, whatever, we promise you that this medicine is going to do this for that patient. But it's very, very difficult to follow up on that. So maybe personalized medicine is not the key to healthcare, but it might help. It might help. Maybe we can find models where personalized medicine helps us to identify these outcomes and quantify these outcomes.
Thank you very much. You obviously agree, but are there any other elements that are key alongside personalized medicine for sustainable healthcare?
It was mentioned before, the issue of prevention. I think that we can do a lot more about that. And prevention is, in my opinion, something that can start here in Brussels, because prevention has a lot to do with politics. It has a lot to do with smoking, regulations about food, regulations about exercise, etc., etc. So Brussels is the real problem. Brussels is not the solution. Brussels is the real problem at this moment, because the whole regulation is supporting industries like tobacco industry, food company, alcohol industry, and etc., etc. So that is the real problem that can be solved here, as we speak, in this capital of Europe.
Agree, and there's a lot of evidence also in economic prevention, how you can put incentives in place in such a way that you maximize prevention. Point I want to add is that you mentioned quantification and measurement. I think if we really want to put the value of individual patients at the core, we should really start collecting data about it. So having patient-reported outcome measures, collecting that. You mentioned the breast cancer. I think I now have to work with only a limited group of countries that has the prompts on breast cancer as prescribed by ICHOM. If you really have in a broader way relevant outcomes from patients in the documentation, part of the electronic health records, and use that for steering and financing healthcare, we can capitalize on the promise of personalized medicine.
Thank you very much. I will take the very final question. I will just go here since I will go here since I think you asked the first question, so if you don't mind. Wasn't you? Sorry. Okay, very short. I'll give it to both of you. So like that, my events team will kill me, but please make it short and fast.
Very short question. Thank you very much.
The answer.
Brian Heitz, I work for the Dutch Ministry of Economic Affairs. We deal with the digitization of society. Therefore, data.
Sorry, Brian. You don't have a mic. Yeah, sorry.
Thank you very much, Brian Heitz, Dutch Ministry of Economic Affairs. It's all about data. If you collect data, then you can provide personal health medicine in the future. What would you advise politicians and policymakers in Europe and the national countries to do in the respect of free flow of data across Europe in order to make personal health medicine possible?
Well, I like to answer that question because Estonia now is the chair of the European community, and I was in the task force about the data problem and what to do about it. And I think, well, the data is owned by the patient. That is one of the statements made by that working force. The data is also maintained by the statement. That's the second one. And the one that I really wanted to add to that is that data is always available for good research. I think that is a prerequisite that we never may forget. We have to make that data available for research, and that is exactly what we patients want. There are always lawyers and bureaucrats and politics that talk about the data that is not available. They talk about privacy, they whine about privacy, but patients want their data to be available for research, for better treatments. In the end, that is what delivers the better quality of life for patients and their loved ones.
Just to add on that, politicians should not be guided by fear of data privacy and data security, but have a rational approach of dealing with that, and really think in terms of learning. It's not just the data, it's a learning capacity and a knowledge-intensive industry that you are developing. So if you take that perspective, there are lots of ways to do it, and that can be by the standardization in your health records, by the data linkage possibilities. The technical possibilities are there, but I still sense that a lot of the policies are rather from a fear position than from a we can use and build on this position.
Thank you very much.
What to advise the politicians? Well, I would say that they might create the framework on how we collect and how we work with data. And this is extremely important because currently some countries are doing something, others are doing another thing. Patients moving from country to country not always can bring their data with themselves to the next doctor, etc. But creating a framework that is common for all of us, putting some basic standards of how we collect data, who is responsible for that, what type of data, and how we can use it between the different countries is something extremely valid and valuable that the politicians, the member states, and European institutions can do. And of course, on the top of that, providing the necessary tools to the government to start implementing in countries. Like funding, but not only funding. Sometimes they don't do it because they don't know how to do it or what to do there. And I think it's time for Europe to stop being really, we don't want to mix in the member states' issues, etc., but simply saying to a member state, you are not doing well in the digital health in your country. Sometimes member states need also proper guidance on how to do the things faster and better for their citizens, and I don't think any member state would be angry if they receive such kind of help and solidarity from the rest of the member states.
Thank you very much. I'm afraid the time of the opposing team has run out to respond to the question. And the very final question, to pay my sins to the gentleman in the back that I confused. Sorry about that.
Thank you. It's another beautiful guy over there. Thank you for the possibility to ask the last question. I'm working for the main association of Austrian social insurance institutions. So I'm representing a system based on solidarity very much. And personalized medicine, for me, also implies that we know a lot more individualized data about the patients. And for me, for this reason, the question comes up if the debate about solidarity will come to a new, I wouldn't say to a new level, but to a new question, because if we know more about the patients, then we may ask the question again, well, did this patient live his life correctly? Shouldn't he maybe have started doing sports earlier or stopped smoking earlier? So yeah, for me, the question is about solidarity. What will personalized medicine will have to do with solidarity? Thank you.
Can I start with the opposing team?
I think the discussion that we had on the previous question shows that personalized medicine has a whole lot to do with solidarity. Because if you buy into this concept as a patient, you will have to contribute data to the whole sum of knowledge so that this data can be used. You will have to give up some of your data. Now, politicians have the responsibility to ensure that this is done in a responsible and depersonalized way. Personalized medicine with collecting personal data should be compatible with collecting outcomes in a depersonalized way for statistical analysis. And it should also enable the individual patient to have access to his or her own data. But that does not mean that we have a big brother watching over us and say, okay, you're not going to get this or you're going to be penalized because you stopped smoking. I don't think Europe wants that.
Thank you very much.
Well, I think you should turn your sick funds into health funds. You're still in an old design model where that stems from the Bismarckian periods where people got ill and needed some support for the healthcare costs. But you see that several insurers in insurance-based models in Europe are taking that route, are broadening and have a population-based approach that has consequences. It has consequences of how long an individual stays with a certain payer. But from this perspective, if the payers can make the switch from sickness funds to health funds, and we find ways of, we are now experimenting with population financing to put the financial incentives in such a way that we stimulate people to keep their health, then we go in the right direction rather than only sitting at the sick funds and kind of punishing people for their behavior. Again, in the prevention field, there have been debates for centuries about this, and yes, the punitive approach doesn't work. So let's learn together.
Peter?
Yeah, maybe some words about the solidarity. I think that's very important to be very, that there should be a great solidarity. And you talk about people who do not look after their own health, but be aware. I was one that blamed smokers from getting lung cancer until I met a very famous and awesome Dutch lung doctor who learned me that at the age between 13 and 18, young kids are made addicted to cigarettes, to tobacco. And so don't blame these people for getting sick because of industry. Here in Brussels, there is the problem about regulation for tobacco industry.
Thank you so much, Peter. I'm sure that people who represent SME institution in the room will want to have a chat with you at the end and tell you that is the member state's fault and not the EU institution's fault.
You promised me that you would mute me if I would go too far.
No, we don't do censorship, just time-wise.
Well, she said so.
just with time. So we will go to the last 2 minutes for each speaker to make their closing arguments, and we will start. We will follow the same succession that we followed at the beginning. We will start with Nick. 2 minutes closing argument. You want to stand up for a change and exercise for half a minute.
I hope this debate made clear that the personalized medicine is not just about pharmaceutical industry. The point I would try to make is that healthcare is a knowledge and technology intensive industry. It will remain that, and its survival depends on using and applying that knowledge and those technologies. To make it sustainable from a financial point of view means that we really have to think through our data infrastructure, tackling waste, and redesigning the delivery models and the financing models. But I rather take that stance and take that as a challenge and go with the future than stop by seeing all the things that might go wrong, because that will stifle, in the long run, medicine and will just devalue for everybody. So again, let's learn together and let's use the information that is available.
Thank you very much. Do you still have a closing statement? Do you want to stand up and make it?
Okay. So I'll just sum it up from my point of view. Personalized medicine is not the key to sustainable healthcare, but it is a tool. It's another tool. It's just another tool. There are other tools which are just as important. More emphasis on prevention, be it personalized or a really cool ad campaign to make kids stop smoking. Prevention is another tool that's very important. New payment models is another tool, again, that we have to think about. There are many ideas out there. Politicians just have to have the courage to think about them and experiment with them. Delinking the price of a product from the value that it has, for example. Solidarity is another tool that's very important to making sure that healthcare remains sustainable. And yes, personalized medicine can help and can enable us to evaluate the healthcare interventions that we are practicing and having a feedback and seeing, okay, do they really work? Do they work in real life the way they did in clinical trials? So yes, it's a tool that we can use and that we can help, but it's not the key. It's not the only thing. It's not the cure-all. But it's very important and it can help us. But the patients are the most important thing, and I think when we talk about personalized medicine, we should not forget privacy issues, because that can destroy the whole thing. So I'm finished. Thank you.
Thank you very much. Peter, please. Thank you.
Yeah, I liked your statement that you were doing personalized medicine for because you're a doctor. Because it was Hippocrates who said, "I will only come for the benefit of the sick," and I think that is what is needed. Let me phrase another good friend of mine, Sharon Terry, who said, "If you're not at the table, you're on the menu." So I think it's very important, if we really want to make a success of it, and I think we can. I call it put different people in a room. And it's kind of a bizarre that if you want to change, you have to change comes from the outside. It's kind of a bizarre that change comes from patients who are now entering healthcare. It's bizarre because it should be about patients, but healthcare so far wasn't about patients. Patients were on the menu. Now let's get them on the table, put different people in a room and look from it from different perspectives. I think we are too kind for each other in our discussions about what should be done. We don't talk about the real interests in healthcare. Patients, researchers, clinicians, people from government, industry, health insurance companies, they should be at the table having discussions about the real interests and be honest about that. I work at the central bank. I'm used to economics and I'm used to the way they talk about issues. Put that into healthcare. Realize that there are also interests from the economic perspective. Businesses like Philips, businesses like pharmaceutical companies want to make profit. That is honest. Put that on the table. Be independent. You can't be independent. No, of course you can't be independent. But if you are together in this and you have to agree upon that we really go for our own interest, then you can be sort of independent and you can look for the win-win. Because I think that win-win is possible to achieve. So put different people in a room, go for the root cause, be independent, and if you found a solution, scale fast.
Thank you very much.
I'm actually a true believer in personalization of medicine. You probably know that. Because I do believe that this would definitely make the patient's life easier, probably the doctor's life easier in a way, etc. And I do believe that someday medicine would really be very much personalized in all aspects, starting from prevention, going to treatment, and to all other elements of the healthcare systems. But what I tried to do this evening is to make a big red line to many of you that there are patients that actually don't have basic access to even general practitioner right now in Europe, around us, just because they live somewhere. There are patients who have no access to any technology that can collect data. And are we going to exclude this type of patients in the future from the personalization of medicine? What are we going to offer to them? Are we really thinking of all these aspects? And do really the politicians do enough so one day the personalization of medicine would be reality, at least in our world, what we call European Union? So now with my speech, I would ask those of you who are also worried and would like to put the big red light to the decision makers, to the policy makers, to those in the room who are actually driving this process, to vote with the red. Thank you.
Thank you very much. So Stanimir did a great job reviewing what's going to happen now. We hope that this debate and this format, challenge some of your points or maybe reinforce some of them. Hopefully you learned something new or you wondered more after this debate. So we will see whether our speakers and the debate change your mind from the beginning of this debate. So I will call again for a final vote. All of you who believe that personalized medicine is the key to sustainable healthcare, please raise the green cards. Okay, just the green cards for now. I'll look at the red afterwards. I won't count, but I just want to get an idea of how widespread it is. Thank you very much. And then, as Stanimir called, those who are against the motion?
Yeah.
Okay.
Much more than the first time.
Right? Okay. So it looks like we started with more people being for the motion, and we ended, I wouldn't say with more people being against, but a higher number of people being against. So a few of you, at least, have changed your mind. So I guess congratulations to the opposing team and to Stanimir. Which doesn't mean that the motion, I feel right now like a chair of a European Parliament committee. Now I understand how bad that position is. Doesn't mean that the motion has been dismissed. It just means that there's been an obvious shift in the votes in the room. So I would like to thank very much to our speakers who played this game with us. I would like to thank you for making my job even easier and not having me ask questions. You asked all the questions, and that's really great. That means you're really involved in the debate and in the conversation. And I would like to ask everyone to stay on stage as Sarah goes back to the most difficult job of the evening, which is to summarize a bit the conversation tonight. Thank you.
Thank you all. Well, before I get into my little analysis, I want to thank you all for coming, and I want to thank Philips for allowing us to have this event here. And I do have a background as a political reporter, so a little bit of voter analysis is actually my thing. And I think the main issue here, maybe the reason for some of the changed views is the power of skepticism. Ultimately, everybody agrees that, on stage seems to agree that personalized medicine holds huge potential. Everybody agreed that it's going to take huge changes to the health systems and pretty much the way we do everything, whether it's paying, whether it's diagnosing. And so it came down to skepticism about whether we're really going to be able to do that on any sort of reasonable time frame. As Anna said, you just have to have the courage to make those sorts of changes. And perhaps those who found themselves holding up some red cards didn't see that courage coming. So that's my little political analysis for you there. And what else am I supposed to tell you about? Oh, my other favorite thing, networking cocktails coming right up. But before you do that, we have to ask you to give your opinion one more time. It's a little more complicated than the red cards. You have evaluation forms. If you really want to make me happy, you can hold those up too. If you could fill those out, it would really be helpful for us. And I will let you get to the drinking. Thanks so much. And thanks to all our guests.
Because I'm happy.